Well, good afternoon and welcome to this GIRFT and NHS resolution webinar for clinicians, managers and legal teams. I'm John Machin. I am the clinical lead for litigation at GIRFT and I run the litigation workstream along with Professor Tim Briggs. I'm a clinical fellow in trauma and orthopaedic surgery, currently working in Vancouver, and I'll be shortly returning to work in Oxford. Thank you for giving up your lunchtime to be with us today. We hope you find this session useful. Next slide, please. So this is the agenda for today. We have a wide range of speakers, both from a clinical and legal perspective, who can give us both a national and local view and take us through the support available both from GIRFT, NHS Resolution, and also NHS panel firms, as well as your local legal departments. Learning from litigation is an improvement opportunity which historically has not had the attention it deserves. So we're pleased with the interest this work has generated. There is still much to achieve, and the COVID-19 pandemic, just like everything else, has provided both us a fresh set of challenges and also a fresh set of opportunities in this area. We're grateful to all of those who have contributed to the best practice guide, either through the GIRFT visits or directly to the text itself. I would also like to recognise Sir Robert Francis QC for his ongoing support of this work, his statement of support in the guide, and for his BMJ article recognising the importance of this issue for patients. If you have any questions during the webinar, please enter them in the Q&A box. We have disabled the chat function. We would like to encourage you to ask questions, and the speakers will also be joined by Joanne Eastbrook, who will answer questions on behalf of NHS panel firms at the end. Patricia will be picking up the questions from the Q&A section, so we will be ready for you on that front. We are recording this session today, and it will be available on the GIRFT website, and you'll receive the link after this webinar. Please send any further questions you have after this webinar to the GIRFT litigation email address, which again will be shared with you after the webinar. Next slide, please. So we're going to start the presentations today with Professor Tim Briggs. He's the National Director for Clinical Improvement at NHS England and Improvement. He's also the chair of the GIRFT programme and of course a practicing consultant orthopaedic surgeon at the Royal National Orthopaedic Hospital. So without further ado, over to you, Professor Briggs.
Thanks, John, and welcome everybody. It's great to see so many people on the call. As you know, I run the GIRFT programme, and it's been a review of 38 clinical specialties using data to drive change and led by frontline clinicians. And the peer-to-peer engagement is absolutely pivotal in terms of the success. We've had support from all trusts and SCPs, and what we've done is locally designed improvements, which will now be at system level, and very important now as we're driving post-COVID. Next slide, please. So this is what happened pre-COVID in orthopedics, and you can see that we've made significant change. We've improved patient care, we've reduced readmission rates, we've stopped and reduced inappropriate surgery, we've reduced infection rates and revision rates, and very importantly, we've seen a reduction in year-on-year claims of litigation. All of that is better patient care and better value for money for the taxpayer, allowing us to do more work. Next slide, please. And then, of course, then came COVID, and we know the output of that. We've seen it on the news. We've got about 5 million people waiting on surgical waiting lists. We know that we've got a huge number of patients who have yet are hidden and unreferred because of COVID, and therefore we've got to come and transform our services in order to make sure we provide a timely care for our patients. Next slide, please. We know that all regions have been adversely affected, so we've developed the high volume, low complexity pathway transformation process for surgical recovery across 6 surgical specialties to actually be the vanguard of elective recovery. We know if we do this correctly and we maximise at the top decile of outcome in terms of the GIRFT metrics, we're going to improve patient care. We've developed pathways, 29 of them across 6 surgical specialties, of which we expect 85 to 90% to be day case. And we know if we standardise the top decile, again, we'll see better outcomes, low complications, low readmission rates, all for the benefit of patients. And these have been developed by local clinical experts, signed off by not only the regional CAGs, but also by the specialist associations and specialist societies and the Royal Colleges. And it has been a wonderful exercise to see, whereas before COVID, 29 pathways would have taken approximately 29 years. We did this in 7 weeks, just demonstrated how clinicians are really up for driving change and standardizing pathways, which had never happened across the NHS before. Next slide, please. So what we've done is we've developed gateways. This means that trusts and systems can look at where they want to be, which is the red triangular box here. This is the top decile in terms of metrics we want to see in orthopedics. This ICS you can see on the right has now populated it and see where they are and where they need to go. This is going to be much better for patients, and what we want to do is support them in how they get there to standardize at that top decile, which is the new beginning, but we still want year-on-year improvement. Next slide, please. We've also developed pathways, 29 of them, end-to-end, from primary care right through to secondary care and right through to community. And again, as I said, I'm so proud of the clinical community to develop these 6 in orthopedics, but 29 in total across 6 surgical specialties, which represent of this work, the high volume, low complexity work represents 53% of those waiting lists. Next slide, please. So here are the pathways. You can see them there, absolutely buy-in from clinicians. And as we go forward, we will be producing and developing further pathways that will aid better care and standardization of other specialties. Next slide, please. So why do we need to do that? Well, here's the problem. We know that the current provisions for liabilities of known claims is 84 billion. In 2019-20, it was 2.3 billion for cost of clinical negligence schemes, which is an 85% increase in the cost from 2014 to 15. So we feel our program, both the GIRFT program and what we're doing now with the high volume, low complexity, is absolutely essential to help control and reduce the litigation burden on the NHS. Next slide. So this is what I found initially. So this is going back to 2013 when I visited this big city in the north of England. There were 10 trusts, and you can see the variation there in the litigation cost per trust. The range across the country was from £0 to £154 per orthopaedic case. But look at this city where there is significant variation between £31 per case and £134.90 a case. And the key was that no one had really looked at this data or sat down in the room with the clinicians to work out what the issues were, how could they improve. And what we found when we analysed was the 4 big things were judgment, tissue damage, procedure, and unsatisfactory outcome. Next slide, please. So this is why we developed the litigation work stream that John and I lead. There was no real national programme for learning for the negligence claims. There was no best practice guidance in claims handling or claims learning. And there was no measure for hospital performance or incentives and best practice. And really at that time, there was no guidance for frontline clinicians. So we decided we had to do something about it. Next slide. So every year now, every trust gets their pack across all the surgical and medical specialties, which highlights where we are in terms of litigation cross specialty. And each of those bars on each of those graphs represents an individual trust. And just look at that variation of what we've identified. Just look at trauma orthopedics. For that, from 2013-14 to 17-18, 689 million in claims, 6,200 claims, minimum £11 per case, and the maximum 881. So we knew that we had to do something about it. And by showing this sort of data, we have absolutely moved the dial. Next slide. So what we can do now is we can break that down for individual trusts into specialties. And here you've got a very good trust, in fact, but they've got 2 areas where they're in the red zone where you don't want to be, or max fax and also ENT. So it gives the trust an opportunity to look at what they're doing well, what they're not doing well, and then what to work on over the next 12 months to try and absolutely improve. So this data has made a massive difference. Next slide. This is what's happened in trauma and orthopedics, and we've been absolutely delighted with what's happened. And you can see that we've had a significant drop year on year, right through to 1920. And we predict that that has actually saved the NHS over £145 million. And so we know that once you show this data, you can actually stimulate clinicians, management systems to actually drive improvement. Next slide, please. And we're now starting to see reduction in other specialties around breast surgery and obstetrics. I'm not saying GIRFT is the only reason for that, but what it is part of a new movement to highlight this data and ask and help trust drive change. That's all. So our strategy to contribute to the variation in litigation costs is, how do we help the clinical performance of the department involved? How do we help the performance of the legal claims handling within the trust? And then how well does the governance structure within a trust learn from claims? And how do they share that with frontline clinical staff to improve patient care? So these data packs are crucially important to actually highlight to trust where they need to work on, what they're doing well, what they're not doing well, and what they need to improve on. So we've also developed best practice guided learning for litigation claims of clinical managers and clinicians, which we're going to present today. Next slide. So also documentation. This is in orthopedics, but we're now extending it to general surgery and other surgical specialties. Now, what documentation is imperative that we need to put in to help us when there are claims against us in terms of trust litigation, just to make sure we've covered all our bases and we've entered the right information. And these have been developed with the specialist association societies to actually make sure clinicians have all the information that they need at their disposal. Next one, please. So what are our objectives? So we've got the National Programme for Learning from Clinical Negligence Claims, best practice guidance, measure of hospital performance in centres of best practice. So the litigation data packs refresh is May of this year, and guidance for frontline clinicians, hip and knee arthroplasty, but also general surgery and other specialties too. Next slide. Thank you.
Thank you, Professor Briggs. So we've done a quick whistle-stop tour of where we're at with the GIRFT programme and looked at what we're doing in terms of litigation. Next slide, please. So I'm just going to go through our learning from litigation claims best practice guide, some of the highlights. So why did we carry out a best practice guide? Well, Professor Briggs has covered some of these elements already, but we've received feedback from GIRFT visits from clinicians and managers that many of them were unaware of the claims against their department and therefore unable to learn from them. We know that claims learning has been missed often from departmental meetings and clinical governance structures. And across the system, claims learning has not had the attention that is required to achieve the potential improvements, both in patient safety and the resulting reduction in costs. So it was clear to us that we needed to provide a structure for learning from clinical negligence claims that can be led by trust legal departments, but supported by clinicians and managers. Next slide, please. So how did we create this guide? Well, we used the best practice that we came across through the GIRFT specialty work streams as our clinical leads travelled across the country, meeting all the different teams that work in their specialty. We took feedback from the litigation data packs, and we carried out some specialist GIRFT litigation visits led by Professor Briggs and Mike Hutton, our spinal lead, along with our clinical fellows, both visiting legal departments and visiting a number of high risk and high priority clinical specialties, both visiting those trusts that were doing well and those trusts that were struggling to see where we could make a difference. And then, of course, we've received feedback from NHS resolution and panel firms as well. Next slide, please. So the first thing I would like to go through is about claims handling to facilitate learning. So this is where the learning really starts. So claims reporting should include the relevant clinical details to facilitate learning at both a local and national level. And we found that trusts that do it particularly well are where that the clinician has been allocated time in their job plan to carry out this role. So we recognise it is it can be time consuming based on the number of claims available, but in those departments where there are a higher volume of claims, it definitely helps having a clinician available to provide this additional impact. And as you can see, here are a list of clinical details that we think are important that should be added when the claim is submitted to NHS resolution. Next slide, please. So what are the resources that are available? We have a learning network that we can call upon. Obviously, we have the trust legal departments, and along with claims, they're able to supply to us information based on inquests. We obviously have the complaints department. We have the patient safety department who are able to feed in on incident reporting. And we have, of course, the clinical teams that we want to link all this up with. Then externally, obviously, we have NHS Resolution, and NHS Resolution, who are going to speak in a bit, have two things that they can offer really. They have both the claims handlers, which your trust legal department will be familiar with and can give direct feedback on individual claims. And they also have a safety and learning team who are able to provide additional resources and support. And then finally, we have the panel law firms. These law firms, again, are specific to your trust and are able to give you feedback on particular claims, but they also provide value-added services. So they have educational offerings and forums, and it's important that everyone at the trust is aware of these and can take advantage of these. Next slide, please. So, as I've mentioned, the people that are key to the process are complaints, patient safety, and clinical teams working with the legal department. We also need to work and recognise the role of patients, families, and carers. These need to be involved with safety investigations. We know as clinicians it's important to have openness and candour and to signpost them to the support and commit to sharing it, because often breaking down these barriers and involving them from the start really helps the process and enriches the learning as well. As I've mentioned, we need to review the claims, the complaints, the incidents, and the inquests, and we need to triangulate this learning to really work out what focused improvement needs to be carried out. And then finally, it's important that the clinical department's claims are discussed on a regular basis as part of the formal governance structure, so that we're able to provide that feedback and share it amongst clinicians and frontline staff. We think that at a quarterly basis is a good time frame to aim for these departmental meetings. Next slide, please. So these are just a few examples. We saw many more examples as we went across the country, and these are not the only trusts doing these specific measures, but we're just going to highlight a few. So we found at Guy's and St Thomas's, they have consent clinics, and these consent clinics are important because they provide the spinal surgeons in that hospital time to really go through an informed consent process with the patients. And these occur at least 2 weeks in advance of the surgery, and this allows a cooling off period. And we really think that trusts that are carrying this out really see the benefits in terms of their claims against consent and dissatisfaction with surgery. And then another example is the Hip and Knee School, which is being carried out at East Lancashire Hospital. Again, a really great initiative, and we know it is very positive for patients to have the preoperative education sessions, to meet staff and to be aware of the logistics of the day-to-day surgery, but also to be aware of the follow-up and what to expect. And this definitely improves patient experience. Obviously, Professor Briggs has already mentioned our documentation guidance, and this is obviously key, and we'll be providing more in other specialties as well. Next slide, please. So in the guide, we've included a number of suggested areas which can be monitored, because we know when we wish to drive improvement, it's important to have some standards against which you can monitor your progress. So these are obviously included in the guide. Next slide, please. So just to close this section, I'm just going to go through the key points. So the first point is that we've recommend appointing a dedicated clinical member of staff to assist with trust legal teams to highlight patient safety issues with sessions incorporated into their job plan. We would also recommend regular discussions of claims with clinicians in forums such as clinical governance, MDT meetings, and to really introduce this focus on improvement through claims learning. Thirdly, it's important to make clinicians more aware of the claims process and ensure legal teams are more visible to clinical staff, because an improved relationship means that we can all work together better when a claim comes along. 4, ensuring clinical staff are aware when a claim is initiated is important, and staff really value that because they might be continuing to see those patients. And it's important that we support each other through this process. And then 5, working in partnership with patients and families and carers is important, so that they're involved in investigations and that we really foster this attitude of openness. Next slide, please. So I'd now like to hand over to Simon Hammond, who is the Director of Claims at NHS Resolution. Over to you, Simon.
Thank you, John. And good afternoon, everybody. I'm going to talk to you just a little bit about the practical side of things from a claims perspective. So if I could have the next slide, please. Thank you. So whilst we recognise that the guidance promotes the triangulation of complaints, incident reports and claims, we do recognise that not all claims will start as a complaint or incident. Now, although that's not ideal, the claim notification may be the first time that the patient expresses dissatisfaction over the outcome of the medical treatment. So it's therefore important to ensure that, irrespective of the time lag which occurs from the adverse incident until reporting of the claim, any learning from that claim is captured. To assist in facilitating this, having accurate data at a local level is essential, and the guide provides a helpful checklist for what data should be captured. Now, not all of this data is required by us, NHS Resolution, for the purposes of claims management, but that data will help identify potential areas for learning that can be discussed between the claims teams and clinicians at a local level. Guide specifically highlights the need to ensure, as far as possible, any errors in coding are rectified, but we acknowledge that there's always going to be some grey areas around that coding. Now, as John's already mentioned, the guide recommends clinicians are made aware as soon as possible that a claim's been intimated. And this has the dual benefits. Firstly, ensuring that clinicians are aware and can provide their comments on any allegations made to help the claims process, but also can help support learning at that early stage. Now, continued involvement in the claims process, even by way of regular updates, can ensure that clinicians feel supported, but also aren't taken by surprise if further demands of their time are required throughout the claims process. It's recognised claims processes can go on for many years. It's important to recognise that any ongoing claim can be an important source of learning. Even though any breach of duty may not be proven at that stage, it shouldn't prevent discussions taking place between the claims teams and clinicians, and any learning that can be taken from allegations made and the factual circumstances of the case. Now, clearly there are some restrictions around privilege at that point in time, but that shouldn't be a totality to prevent learning from open claims. Can I have the next slide, please? Thank you. So as many of you all know, NHS Resolution work with a large number of panel law firms who specialise in healthcare work. And many of your organisations have already worked with those panel firms on matters which don't relate to clinical negligence claims. Now, all of them offer value-added support to the work they undertake for us, which includes healthcare seminars and learning events. The guide outlines the availability of such educational events, which may assist with learning from claims. But this is just one of a number of available resources, which can actually include claimant organisations and bodies who also run events and seminars. And you will note from the guidance that we have actually produced it with the input from a patient voice as well and claimant solicitors. We recognise the importance of understanding all of the available resources for learning from claims. Either NHS Resolution or the panel law firms may be able to provide you with high-level case analysis, as John has mentioned, to assist in the local learning process. Now, it's unlikely that that's going to be required in every case, and the steps in the guide, if they've been followed, should make it apparent if there are learning to be taken from the individual claims. Now, the guide does provide a practical workflow to when a claim is received. The purpose of the workflow is to help staff at a local level understand best practice and the evidence gathering stage, especially at the early part of a claim notification. Now, in line with our member charter, we don't expect us to manage the claim, as that's clearly our case manager's role and responsibility. But the purpose of the steps within the guide are to gather the appropriate data so that the claims team can assist us in the management of the claim, but also have the necessary information to hand to triangulate that with the incidents and the complaints and discuss it with clinical staff at a local level throughout the total of the process. I'd now like to hand over to my colleague, Dr. Denise Schaefer, to discuss the work we undertake in our Safety and Learning Directorate.
So thank you very much, Simon, and thank you very much to the GIRFT team for inviting us today to be part of this very important partnership. My name is Denise Schaefer. I am the Director for Safety and Learning at NHS Resolution. There are a couple of areas that one is doing everything we can in terms of showing the learning and prevention of harm, but secondly, working with provider organisations through some very small number of slides to just look at some of the resources that are available. They're publicly available on our website. Also, members of my small team, I've got Safety and Learning lead for each of the 7 regions, and we've also got clinical fellows working with us. Next slide, please. So here is just an example of some of the materials that you'll see on our website. So we pull out what we call Did You Know leaflets, which give you some very headlines information about the types of claims we see, the costs involved, and some of the preventative actions that can be taken. We also do thematic reviews. We work in partnership with GIRFT and we complement their reports, looking in more depth at some of the thematic analysis arising from some of those areas of claims. A couple of key points here is there are some videos available as well on our website. A very important video from Nadine Montgomery, very compelling story about the importance of consent. We've also got a video there on saying sorry, and we're working on more materials on response to harm in these areas. Next slide, please. The saying sorry is one of our most important leaflets, and we are working this year in enhancing this whole area and helping organisations to work more closely with families, patients and parents and anyone involved in incidents. Just to reiterate, which we do at every occasion, is that saying sorry is always the right thing to do. Meaningful apologies are very important, not an admission of liability. Some of our research that we've done into motivation for claim have very sadly seen that sometimes people take claims to get an answer, and we really want people to be able to get that answer as near to the point of incident as they possibly can. Next slide, please. This is This is a really important piece of work we did in partnership with a number of stakeholders, and it's around being fair, supporting a just and learning culture for both patients and staff. And it particularly addresses the variation that we see across many of the provider organisations. And it's got some very useful tools and framework to follow when incidents occur, particularly looking at fair processes for staff and addressing some of that variation. Would really recommend that you look at that, particularly looking at the charter within the guidance, which is putting patients and families at the centre and supporting staff at the same time. So we'd highly recommend that to you if you've not already seen it. Next slide, please. So this is just a quick snapshot of our claims scorecards. All of you in your organisations will be sent your own data from point of incident of the last 10 years, categorised by specialty. We've created a video on an easy to use guide We are at the moment recommissioning our claims management system, and we're looking at revising the scorecards and working in partnership with GIRFT and others about how we can improve them. In the meantime, if we just go to the next slide, please. It will just show you a little bit about what you can see in that if you're not familiar with them. We're working particularly with the GIRFT lead in ED. We've been looking at a thematic review on claims in emergency care. They're very interested in developing that with us further. We're looking to see whether we can do some bespoke specialty cards this year for maternity and for emergency care. So watch this space, and we'll be talking to some of you around getting some feedback. If you have feedback more generally about the scorecard, we'd be very interested to hear your feedback. Our regional team leads work with a lot of the trusts, and would like to just reiterate the point that John just made, is what's really important is looking at these in the same space as your GIRFT packs, your data packs, your complaints, your incidents, and your MMR meetings, etc., to just pull all of that together, which will give you a really good understanding of some of your contributing factors towards this. Any questions to me, please just email me or email the team. All of our team are willing to come and talk to Trust, particularly with alongside our panel members, to get you looking and being able to use these tools in a more effective way. The final thing is, if you see any errors on this in terms of coding, please will you contact us, and then we can correct those for you. Thank you very much. Next slide. I think that's the last one.
Thank you, Denise and Simon. So now I'm going to go on to talk about the litigation data packs and the 5-point action plan, which we would like you to carry out in response to that data pack. Next slide, please. So this is the front page of the litigation data pack for this year that was sent out at the beginning of May. All trusts should have received a copy, both through NHS Resolution, who sent a copy to the legal departments, or through your GIRFT champion or medical director, who have received a link to the future NHS platform, which GIRFT uses to share all our trust-specific resources. If you haven't received this or haven't seen a copy, then please contact these people in your trust. They should be able to share it with you. We've asked for these data packs to be shared with all clinical directors of all departments who are involved, and all those who have job roles with safety or risk management or improvement roles who we think would find this useful. So please get in contact with those members of your trust who have received this if you haven't seen it yet. Next slide, please. So I'm just going to go through some of the key points and changes for this year's data pack. So just to start with the purpose of the data pack, the idea is to allow your trust to review your performance in all medical and surgical specialties. And this is an example of the surgical specialty table, which is at the start of the pack, so that you can see all surgical specialties together. The idea is for you to be able to see the litigation costs which are lower than other trusts. So those which are in the bright blue column, you can see are one of them there. Those are the areas where the trust is in the first quartile, so doing very well. And also importantly, to see where the litigation costs are higher relative to other departments. And this is an area that probably needs a second look and where there's probably room for improvement. And these are highlighted by the red boxes in the cost per activity column. And this allows us to compare trusts of different sizes, so we can account for the activity by our litigation metric. And we do this by comparing the estimated cost of claims over a 5-year period over the activity of the unit. So that's how the metric is drawn together. The second purpose of the pack is to review claims through our 5-point plan. And we hope through that to improve the accuracy of the data and to learn from the claims through focused improvement. Next slide, please. So we have a new format for the graphs for each specialty. Every bar in this chart represents a trust. The new item is that we now have a different scale for the fourth quartile. And the reason for this is so that the quartiles 1 to 3 are more visible. So we're trying to respond to feedback so that every trust can see their position more clearly on the graphs. Next slide, please. We've also had a change for maternity. So maternity, we've designed a different metric, and maternity has a metric basically based on contribution paid by your trust rather than an estimated cost of claims. And this is possible as we have more information in maternity. So we're able to determine whether your trust's contribution in maternity was more or less than was expected based on the risk profile of your trust. So looking at this funnel chart, trusts at the top of the chart are those with the worst claims experience relative to activity, whereas trusts at the bottom of the chart are those who have the best claims experience relative to their activity. So we hope this is more useful and also directly relates to the actual costs that trusts pay. Next slide, please. Importantly, we have an appendix at the end of the data pack, and this has a list of claims which underpin the data. We have added member trust references this year, and this is based on requests that we received from the last data pack. However, we strongly recommend you use the NHS National Claims Reference number wherever possible. So we are trialling both reference numbers this year. But we will see how things go in terms of feedback, and we'll decide moving forward which one to work with. But overall, we would like to aim to work on a national number so that we can recognise these clearly through a national system, and it makes it easier for all involved. Next slide, please. So in terms of the 5-point plan, we obviously want you to use these when you're reviewing a department's claims. So the first point is to assess the department's benchmarked position compared to other departments nationally, as we've seen on the graph. Then point 2 is to confirm the correct coding to that specialty with the trust legal department, and obviously inform NHS resolution if you see any discrepancies or anything you'd wish to change. Point 3, we'd like a detailed review to be carried out of claims, and we recommend using the resources of witness statements and panel firm reports. We know that trusts find these particularly useful, and obviously patient records are key too. And then, as we've mentioned already, point 4 is the triangulation of claims with learning themes from obviously complaints, inquests, and patient safety incidences. And where a claim has not been investigated as a patient safety incident already, we would recommend this is carried out. And then the learning should be shared at department clinical governance meetings or MDT meetings. And then finally, point 5, trusts outside the top performing quartiles, so quartile 1, we'd like to offer support through GIRFT and NHS resolution, both through our regional teams and through national guidance. Next slide, please. We will come to some of these questions in the question time. Next slide, please. Thank you. So I'd now like to hand over to Brady Poole, who is the Interim Group Deputy Director of Patient Safety and Risk at the Royal Free in London. He's also, until very recently, the head of the legal department there. And we've learned a lot from our discussions with Brady in the past. So I look forward to his presentation today. Brady, over to you.
Thanks very much, John, and good afternoon, everyone. Next slide, please. So I'm just going to give you, just run you through very briefly what we do at my trust in terms of trying to learn from our claims. In no way would I suggest that we have this cracked, and we're learning all the time about how we can learn more effectively. So any suggestions or comments would be, really gratefully received. But essentially, we have tried to ensure that learning from our claims has been integrated within our processes, and that is set out within our policy. So it's one of our key objectives, as you can see there, that we are learning from claims. The triangulation with complaints, incidents, serious incidents, and inquests, etc., is as part of our process, and I'm sure most of the trust, legal, and claims departments on the call would do the same, is that we do this at the outset. So as soon as we receive a claim, we will be checking about what has gone before. Obviously, it's essential that we know all about the history of the case. So this is extremely important. And then when we're thinking about the opportunities for learning, well, obviously at the outset, we can see if there has already been some learning taken from this case in the other processes. But then when we send the details of the case to the clinicians, that will be a key stage for us to consider whether or not there is some learning that we can take from the case. Obviously, when we receive our expert reports from the experts appointed by NHS resolution to comment, that will often be the stage at which we together realize with the clinicians that perhaps there are some learning points here that may not have been appreciated previously. And obviously at the very end of the case, we think again about whether or not there are any learning points we may not have already picked up throughout the process. If we could just go to the next slide, please. So this is just an extract from our process flowchart that that my team use and work by. So you can see that where I'm asking my legal team to think about learning throughout the case, but particularly when we're looking at expert evidence and at the very end of the case. Our focus is very specifically upon cases where there has been an admission of breach of duty, or the expert has identified some learning points. But as the other speakers have said today, clearly we need to be thinking about learning in all cases, not just these cases. But from my perspective, it's essential that we're picking up the learning in the cases where there has been a clear error or learning point identified. If we could go to the next point, please. Next slide, sorry. So when it comes to what we do when we do identify that there is some learning, the legal team will send a learning from claims report to the relevant clinical division. So this is in cases where we've identified a learning point that has not been picked up previously and requires some action. So we'll set out a brief factual synopsis. We'll summarize the expert opinion and provide the team with access to the expert opinion. And we'll give a brief indication of what the outcome of the case was, if it has been completed. Often this will happen before the case has been completed, and what we think that needs to be done. Now, because we're lawyers and case managers, we're not necessarily going to know exactly what needs to be done from a clinical perspective, but we'll certainly set out what we think needs to be done. And usually that's that the clinicians need to really look at this carefully and see what changes need to be made to their service. Next slide, please. Them sharing the learning. So we hold training sessions for staff on a regular basis for certain staff groups, but also on an ad hoc sort of basis on request for different services. We attend quarterly quality and safety boards. That's what we call them within our trust, but they're a division-wide quarterly meeting that is focused on complaints, claims, serious incidents, and safety issues generally. So we will report at those meetings and we talk about claims there. At one of those quarterly meetings on an annual basis, we'll provide a summary of the learning from claims that has taken place. So we'll provide a broad overview of the learning from claims reports we've sent across the trust, and then we'll focus in on the cases that were relevant to that particular division to ensure that they've all been picked up. There's board level reporting in that there's a quarterly report that we call it a CLIPS report, but it's a learning report, again, that includes information about incidents, claims, PALs, inquests, serious incidents. So all of that information is put together in one report, and that's reported to one of our board level committees on a quarterly basis. But as I put there on the slide, we haven't cracked this yet because we haven't quite worked out how to close the loop. So we are feeding this information into our clinical colleagues, but we haven't worked out a way of getting some output from that to us, so that we're sure that we're absolutely ensuring that this learning is being taken forward and embedded. So we're not there yet, but we are getting there. And I think that's the next slide from me. I think that's all I was going to say. Thank you.
Thank you, Brady. And thank you so much to all our speakers for the talk so far. My name is Pratusha Babu. I'm the clinical fellow working with GIRFT, and I'm a children's intensive care doctor by background. I'll now be chairing the final part of our webinar, the Q&A session. Thanks so much for the variety of questions that have come through the Q&A box. Firstly, I just want to answer one question regarding claim reference numbers. We sent them out in our data packs as a PDF, but if anyone would like them in an Excel spreadsheet, just to email our team. I've put the email address in the Q&A box. If I may, I would like to start the session with asking the first question to Joanne Easterbrook. So Joanne, thank you so much for joining the panel. Joanne is a partner at Bevan Breton and has a wealth of experience in this area. The first question, what support can NHS panel law firms provide to trusts for claims learning? And would you be able to give some examples?
Thank you very much, and good afternoon, everybody. It's a pleasure to join you today. I think I have to say that I'm delighted to see claims taking a more important role in the overall clinical governance structures in the members' trusts that I'm working with, and looking at the best practice guidance and the recommended framework for monitoring claims learning. I think that all of the panel members, law firms, are able to provide support across the metrics, ranging from general to specific support. So if I can just mention a few things that we do, and some of them have been mentioned already in brief. So as Simon had said, panel law firms run seminar and webinar events which provide opportunities to discuss and learn about current themes. And these have presentations from experienced medico-legal experts as well as lawyers. And historically, these have been attended by legal services departments and professionals and managers within member trusts, but they are also open to clinicians, and we're always very pleased to have them along. Last week we had one on common legal issues in general practice, and I can see that there are two events from fellow panel law firms this week, both on Wednesday, on record keeping and investigating claims. And it's always a good idea to have a look at the NHS resolution website to see what events are coming up. And these events can also, in normal times, offer the opportunity for local members to network and share themes and best practice between themselves. And as has also been mentioned, most framework agreements provide for member organisations to receive bespoke training, and this is often quite usefully provided to particular clinical departments, which then gives the opportunity for clinicians to ask questions and to focus on their own claims history and to learn more about that. And actually, once clinicians start to see how the practice plays out in litigation, they inevitably become very engaged indeed. And after all, they are the ones that can change things. The panel lawyers are also able to provide information and analysis of the evidence and reasons for settling claims, or sadly occasionally losing at trial, which supplements the scorecard and the data packs that members receive. And they do this in a number of ways. They can give immediate feedback following the resolution of a case, which captures the nuances of the particular case, as well as the wider implications for learning. They can also look at data for the claims that they manage and report on numbers, trends and themes, and obviously identify if they see any repeat or systemic issues, so that further analysis can be done. And one thing I think people often don't realise is that panel lawyers are very happy to attend clinical governance meetings and indeed board meetings, and to work with the clinicians who are getting involved in claims management to provide training on the litigation process. And all the trusts that I speak to, everyone agrees that it's absolutely vital for this work to get clinical engagement. And it's encouraging now to be receiving a lot more invitations from trusts to speak to them and to clinicians about claims and the litigation process, and to support them with claims handling and learning. So I would say, don't be afraid to talk to your panel lawyers about your clinical governance processes and what you need to help you meet the 5-point plan and other demands.
Thank you, Joanne. That's really helpful. And just to talk about how we can have integration between clinicians and claims management and panel lawyers, perhaps I can ask John a question, and feel free from the other members of the panel to answer. There are a few questions regarding data, claims data, particularly on coding of specialties and causes and accuracy of that. Would you be able to discuss how to analyse claims if the coding or parts of the data is incorrect?
So thanks for the question. It's a question we get asked regularly. As with a lot of the data we receive from trusts, obviously the data we have is only as good as the data we put in, which is why we've highlighted what are the important areas we would like to be covered when claims data is summarised. But you're correct that some claims are not attributed to the correct specialty, or there may be a change in terms of the specialty allocation. And that's why we've included in our 5-point plan that we would like you to feed back to NHS resolution so that we can improve the data. The whole point of the 5-point plan is that as time goes on, the data will get better and better as you feed back to us, and therefore we can make sure that the data is as good as it can be, so that it is more effective and useful for learning. So it's really important to feed back to us so that we can really improve that. And please feed back to your legal department, because they will have all the information on each individual claim, and they will have the important documents that we've highlighted from panel firms, etc. So they will hopefully be able to give you more details to be able to look into these claims.
Thanks, John. For the next question, perhaps I can direct this to Simon, and possibly Brady and Joanne can give their comments. It was a question from Mariana, how to discuss open claims for learning in relation to privilege. And I think, Simon, you mentioned it briefly in your presentation, but perhaps we could expand a little bit further on that.
Yeah, thank you. We recognise there's going to be situations where the discussion of certain documents that are within the claims process isn't going to be relevant and appropriate at that specific time due to privilege. And I don't think we're expecting anybody to start to waive privilege on those documents that are relevant for those claims. But this was more of a general comment around the allegations that are made and the factual circumstances. So I think Brady alluded to it in his presentation, that if claims are discussed at the point that the process is ongoing and you are asking your clinicians for comments on the allegations made, then that is all part and parcel of the claims handling process, which I'm sure everybody goes through now. And therefore, if there are learning to be taken from that, then it should be done so at that stage. I think more importantly, what we also have to recognise is, just because breach of duty hasn't been proven, that is a legal test. There is always the point that learning can be taken from a claim, and it might not mean that negligence and breach of duty is actually proven in the long run. Even a claim that is unsuccessful because breach of duty is not proved, there may still be some learning that can be taken from that, which will make the patient's journey better in the future, irrespective on the legal test that applies.
Thanks, Simon. That's really helpful. Just one final question. I'm sorry, we're running out of time. And this is for Denise, if possible. There's a question on saying sorry and how important it is. And it was mainly in terms of the timeline and when it would be appropriate. Could this be clarified? Denise, you're on mute.
There's bound to be one of us that did that, sorry. I think it's a really interesting question because it's something that I think particularly some of our frontline clinicians are really needing some support with. And the way we would phrase this is to just put yourself in the eyes of the family or the patients themselves. What is it that they're looking for? So it's all wrapped up in response to harm. People, when they're involved in incidents, what they require at the point of incident is somebody to support them. We call it putting their arms around families, commitment to investigate, and apologies at a number of stages during that process. So a heartfelt apology about the circumstances of which have occurred, the commitment to investigate, and further down the line there may be more formal apologies. One of the things that we hear often is people don't want to apologise because they believe it's a mission of liability. It absolutely isn't. And the best way that I can describe it is to think how we feel. We all are patients, we all work with, we have families that are involved in problems sometimes within healthcare, and it's being human is what being sorry is about, but being meaningful and avoiding words like I'm sorry you feel that way. Genuine heartfelt apologies and commitment to investigate, take action and learn, and then formally do whatever is needed in the next process. The other, just quickly whilst I've got the floor, just a point that John made earlier about data and learning, which is kind of tied up in this learning from harm point, is sometimes one of the reasons we really want you to have a look at your claims data is they will cross specialties. And what we don't want is people to say, well, that wasn't my specialty, is actually say the harm has occurred. So the last thing families want to hear is that was a different department. Really, everyone at the heart of committing to learn. We often see that particularly in areas like misfractures. It could be A&E, it could be imaging, it could be orthopedics, it could be elsewhere. So for families, the last thing they want to hear is you're talking to the wrong department, and being upstream with complaints and speaking to families right at the get-go is the best way to support them.
Thanks, Denise. So as we're moving to the end of the webinar, I'd like to just ask Professor Briggs one final question and then move on to his closing remarks. How do you think the changes in clinical activity during the pandemic and following will affect litigation? Thank you.
That's a very good question, Patricia. I think that first of all, we've got a large number of patients who have not yet been referred. And the question is whether those patients have been affected by those delays. And I think there is some evidence that the delay has been adverse. But I think the pandemic, we had the NHS responded in a very appropriate way to make sure that we weren't overwhelmed. We had a huge pandemic to manage. And I think the key now is to restart our elective recovery, get the confidence of patients back to be referred via their GPs to us in the system so that we can get on and now manage those patients, bring our waiting list down and get back to business as usual, where we're seeing patients in a timely fashion and providing them with excellent treatment.
Thank you for that, Professor Briggs. We hope you've enjoyed and found the webinar as informative it has been for all of us. We will now close the session. Thank you very much.